and which they face in day to day. So I think with a speaker like of a stature of Professor DK Mishra, and along with moderator Dr. T. Singh as a moderator, so today's seminar is going to be an excellent one and very fruitful for all the postgraduates.
Madam, we have
So
got
now,
good attendance also this time. Good attendance.
yeah. With the name of Dr. Mishra and Dr. T. Singh, the attendance automatically increases. So I think I can now pass over to Dr. T. Singh for
Yes, madam.
introduction, and by that time Dr. Mishra will join.
Professor Mahanti has come. Professor Mahanti has come.
Okay. Thank you, Dr. Vatsala Mishra. It is my proud privilege to be chairing this session to be taken by Dr. Deepak Mishra. At the outset, I would like to thank and congratulate Dr. Asrantika, Dr. Vatsala Mishra, Dr. Pradeep, and other executive members for starting the webinars in pathology. This was a need which was felt a few months back, and I'm glad that it has started, and the topics covered are really excellent, and the speakers are good, and the postgraduates, residents, and also the faculty members for the practicing pathologists are benefiting a lot from these talks. Today, the topic is approach to diagnosis of anemias. Uh, I'll introduce Dr. Deepak Mishra once he comes over. In the meanwhile, we all know that anemia is a very, very common problem in all the developing countries, more so in India, because of our food habits, where we cook our food and don't take all the foods which we should be taking. We differentiate between vegetarian and non-vegetarian too much. And nowadays, what has happened is over a period of last few years, we find that most of us who were non-vegetarians are changing to vegetarians, with the result that the deficiency of vitamin B12 has increased. There was a time when the deficiency of folic acid was the maximum, and that was a cause of anemia in our country. But now we find that vitamin B12 deficiency has increased, and severe anemia due to vitamin B12 deficiency is also being observed. And of course, iron deficiency, we know what is the cause. It is a nutritional cause again. And then we know that the folic acid deficiency is occurring because the stores are few in the body. These are for 3 to 4 months only. So anybody who has deficiency of green leafy vegetables is likely to develop folic acid deficiency, and more so in growing age children, where they really need folic acid, they need B12, they need iron, and we find that all these deficiencies result in severe anemia. And then we also find that the iron deficiency not only results in the various weakness, lassitude, paleness, but also it is affecting the cognitive functions of a person. And it has been seen that in children in whom there has been deficiency of iron, the cognitive function is affected because it is essential for myelin formation. And therefore, this is one area of anemias, the deficiency anemias, where we really need a thrust, not only by the Hematology Society, but by various governments, state governments, as well as the central government. Though, of course, the fortification of the common salt has begun, but still a lot needs to be done so that at least we can eliminate the iron deficiency from this country. Going on to the second aspect, and that is the hemolytic anemias. Again, in our country, we come across large number of hemoglobinopathies. If we go to the Punjab, we find Delhi, Punjab, Haryana. There are thalassemias, hemoglobin D Punjab. These are the common anemias. We go to the east and we find hemoglobin E is the culprit. Hemoglobin E thalassemias, hemoglobin E disease, these are very, very common. And especially the hemoglobin E thalassemias are particularly drained on the economy, because at times we find they have to take the blood transfusions also, and it is also affecting the general well-being of such cases. And then we have sickle cell disease, which of course we come across in Odisha. And in Odisha, it is the commonest, but then we come across in certain pockets in Nagpur area, then in Madhya Pradesh, and even down south in some parts of Kerala and Tamil Nadu also, and Andhra, we come across sickle cell disease. Now, at one time, hydroxyurea was the drug which we were giving, because it led to slight increase in HbF, and that took little bit burden of oxygen carrying capacity. So that was very, very helpful. But now we find that some newer drugs are coming up, and these newer drugs are better in the sense that more and more HbF is formed, so that the oxygen carrying capacity of an individual is improved. Of course, this is something which we need to do a lot on antenatal screening of pregnant women on two counts. One is for thalassemias, and second is for sickle cell disease. Now, in thalassemias, we are very well aware of the most of the mutations which we come across in India, and so is for sickle cell disease. And chorionic villus biopsy, which is being taken before or say after 8 weeks, or around about 8 weeks, we find it has yielded very good results. But at the same time, I think we have to make an effort that school children should be screened, and they should know that they have thalassemia trait, or some of them might be having even thalassemia intermedia. They have to be aware of it, so that at a later date, as they get married, they are aware of the fact that a combination of two thalassemia traits, or thalassemia trait and HbE or HbD, may result in intermediate type of hemolysis in such cases. So a lot needs to be done as far as the hemoglobinopathies are concerned. Another common hemolytic anemias is hereditary spherocytosis, and which we come across, all of us come across such cases where school-going children present with jaundice, splenomegaly, and these are the cases in which nothing much can be done.
Excuse me, sir. Dr. Mishra has joined, so we can you can finish this, and sir, we can go to here.
Sure. Welcome, Dr. Mishra. It is my proud privilege to introduce Dr. DK Mishra. He is a known hematologist of the country. He's MBBS from Sambalpur, Odisha, and MD Pathology from AFMC, Pune. And he has done a postdoctoral fellowship program in All India Institute of Medical Sciences, New Delhi. He has been trained as UICC Fellow at Harvard Medical School, Boston, and then also from King's College Hospital, London. And he has worked with the famous Barbara Baines, Professor Barbara Baines, who is very well known and who has written so many books on morphology and hematology. He's also been to Stanford Medical School, the prestigious one, and he is an examiner for not only MD pathology, but also for DM hematopathology and DM clinical hematology. He's a great teacher, and every hematologist, whether trained or untrained, is always keen to listen to Dr. DK Mishra. And currently, he is holding a very prestigious post as Director of Laboratory Science at Tata Medical Center, Calcutta, where he has started the fellowship program in cytogenetics, in molecular pathology, and molecular hematology, which is playing a great role in managing these patients of hematologic disorder. Welcome, Dr. Mishra. Over to you. He will be talking about anemias.
Thank you very much, Professor Tejinder, and my profound apologies that I was a little late because there was an emergency in the hospital and I just couldn't get out of it. So my profound apologies for being late, and I'm just trying to share the screen.
Welcome, Dr. Mishra. Welcome.
Is my screen visible?
Yes. Make it full screen.
Yeah. So thank you very much, Professor Tejinder. And Professor Tejinder is a doyen of hematology in this country, and any hematology program is incomplete without the participation of Professor Tejinder Singh. Even after his relinquishing his position in Maulana Azad Medical College, he continues to teach the young budding hematologists all over the country on the morphological aspects of bone marrow aspirate, biopsies, and my gratitude to you, sir, for chairing this session. And I thank Dr. Asranti Kar, who is the Honorary Secretary of IIPM, to have put this teaching session in place, which is primarily meant for the postgraduate students. And as I have been following the topics, I can find that the topics are very important from the postgraduate teaching point of view. And today's talk is on diagnostic approach to anemia, which will be a case-based study. And as you know, for a hematologist, anemia is, though very simple, is quite challenging at times. And not many hematologists would like to deal with it because it's a poor man's hematology, because anemia is not of the rich. So it is of the underprivileged, under-resourced people in the country who have all kinds of anemia, and they normally reach the hematologist only towards the end of their refractoriness to anemias. So with that little background, I just would like to thank the organizers again. And I bring greetings from my hospital, that's the Tata Medical Center, which is a comprehensive cancer center in Calcutta. As you all know that the classification and pathogenesis, but the entire topic is dedicated to the postgraduate students. Is not meant for the hematologists, not the senior pathologists and faculty in pathology. So as you know that when you classify anemias and discuss the pathogenesis, you always think about the size of the red cells, the chromia of the red cells, and I will give you a brief glimpse of what this anemia is all about. And when you define anemia, you normally say that when the total the red cell count is less than 4.5 million in men and less than 4 in women, the hemoglobin less than 13 in males and 11.5 in females, and a hematocrit which is less than 42 and less than 37. And this hematocrit is not the hematocrit what the counter gives you, but the hematocrit that you get in the packed cell volume using the Winthrop's or Westergreen's tube. Many classifications of and the definitions of anemia are in literature, and this is the standard figures below which we define a male or a female to be anemic. And when you talk about the infants and children, the labels are different. At birth, if it is less than 16.5, at few hours after birth, if it is less than 19, at 6 weeks, 11, at 1 year, it is 12. Childhood period, it is 12. Young teens, it is 13. And at puberty, the adult value is reached irrespective of the sex. So the importance of the label of hemoglobin in the infants and children are also equally important, because it is just not about the the children and the infants are not young adults. So we have to look at the pediatric hematological aspects also, because they form a major chunk of anemics in the population. So as we know that anemias, when we look at, we call them either microcytic or normocytic or macrocytic, depending on the simple value of the mean corpuscular volume. You know, when you talk about very high-end cell counters, you get a lot of parameters in them. Some of them are direct measurements, and some of them are calculated values. So mean corpuscular volume in some of the counters are direct measurement of volume, and in some they are calculated. So when you talk about microcytic anemias, we talk about below a certain femtoliters of the volume of the red cells. It is called microcytic, normocytic, and microcytic. I'll come to that in the subsequent slide. So based on this, we can classify from pathogenetic point of view that you will have anemia when there's diminished production of red cells, or there is impaired production of red cells in the bone marrow. It could be due to accelerated destruction, either in the intramedullary space or peripheral red blood cell destruction. It could be dilutional, either due to increased plasma volume, or it could be blood loss. Either of these four could lead to anemia in an individual. So when we talk about the diminished or impaired production, it could be due to inadequate nutrition. Majority of the developing countries have anemia due to inadequate nutrients. They could be primarily iron deficiency, as we find in most people and most children and women in the reproductive age group. They have iron deficiency anemia. And then you have folic acid deficiency, which is equally common as iron deficiency, more in the reproductive age group. B12 deficiency, protein calorie malnutrition, pyridoxine, vitamin C, anything can be deficient to cause anemia in individuals. Sometimes you can have anemia of chronic disorder. This is because you have a chronic illness, particularly tuberculosis, rheumatoid arthritis, SLE. You have large number of chronic inflammatory states which can lead to anemia of chronic disease or ACD. As I have already mentioned, rheumatoid arthritis is a prototype case of anemia of chronic disease, and so as the connective tissue disorders like SLE and ankylosing spondylitis and things like that. So when you talk about impaired production, sometimes due to the inappropriate secretion of erythropoietin in the kidneys, you can have anemia of renal failure. And sometimes the erythropoiesis could be depressed, as you find in aplastic or hypoplastic anemias, aplastic crisis in certain hemoglobinopathies, and pure red cell aplasia, diamond black fan anemia, and the Fanconi's anemia. They are the prototypes of the pure red cell aplasias. In the other category, which is also quite common in India, where it could be due to inadequate globin chain synthesis or the globin chains being abnormal in nature. And lastly, it could be due to inadequate heme synthesis that also can produce anemias due to a condition called sideroblastic anemias. And a major chunk of anemias in the elderly population could be because of the bone marrow infiltrative disorders, which in the olden days used to be called myelophthalmic anemia. Not many young students of pathology will know what is this myelophthalmic is, but Professor Tejinder Singh and myself, we have gone through this process during our formative years in hematology. So when you talk about accelerated destruction, it could be peripheral, it could be intramedullary, and when it is peripheral, it could be due to the intracorpuscular defect of red blood cells, or it could be extracorpuscular defects in the form of auto or allo antibodies that is found in the circulation that destroys the red blood cells in the peripheral circulation. I have mentioned about the increased plasma volume that can happen in pregnancy, where it could be a dilutional anemia. It can be due to hypoproteinemia, where it could be again dilutional because of the retention of fluid in the circulation, and it could be iatrogenic hyperhydration, and it happens in hospitals admissions, where more fluids are given than it is required to a patient, and thereby there is dilutional anemias. Blood loss can be acute or chronic. Road traffic accidents can give rise to acute blood loss. And when it is chronic blood loss, as it happens because of an ulcer in the stomach or is because of a cancer in the colon, you could be chronically losing blood. The other thing is you could be losing blood in paroxysmal nocturnal hemoglobinurias and things like that. So blood loss in the elderly could be chronic, and acute blood loss due to road traffic accident is quite common in India because of the vehicular movements. So this is a nutshell about the ways how anemia is produced, and it is important to identify them. So what is the objective of today's presentation is to recognize them and to diagnose them by not overlooking the primary problem, by looking at the hematological data, and to top it off, all the peripheral blood smear studies. And treatment, I will not go into great details, but it is also equally important because you will treat based on the mechanism by which the anemia has been produced. So when you come to the hematological parameters, you talk about the complete blood count. Here, I will not go into the exact ways how you can look at the complete blood count. We have gone through the years in which hemoglobin used to be measured by Sahali's hemoglobinometry, and the WBC count used to be counted by Nuber's chambers. We have gone far ahead in terms of doing complete blood counts by automated blood cell counters, whether it is hemoglobin, hematocrit, red cell, white cells, differentials, platelet count, and even reticulocyte count. You see, reticulocyte count used to be done by doing the supravital staining and doing it in the chambers, counting in the chambers, very cumbersome, irreproducible, and very insensitive way of counting retic counts. But now everything is history. So I have spoken about mean corpuscular volume. You know about microcytes, macrocytes, and normocytes. If it is less than 80, microcytosis. Between 80 and 100 is a normal size of the red cells, and more than 100 is usually called a macrocyte. So if it is macrocytic anemia, more than 100, microcytic, usually less than 80, and between 80 and 100, it is a normocytic anemia. MCH is usually not useful. This is a calculated parameter, and a mean corpuscular hemoglobin is not of much significance in the classification of anemias. Whereas the mean corpuscular hemoglobin concentration per gram per deciliter could be highly suggestive of certain conditions, particularly red cell membrane disorders, the prototype of which is called hereditary spherocytosis. So MCHC has got some clinical significance when you look at it in a certain situation of hereditary spherocytosis. Red cell distribution width is a fad of older examiners. They will always ask you what is the role of RDW in the diagnosis of anemia. So in the differential diagnosis of thalassemia minor and iron deficiency, it is usually RDW that comes up for discussion. Usually RDW is normal in thalassemia minor, near normal, and it is abnormal in iron deficiency. So when you see the peripheral smear after looking at the complete blood counts of a blood cell counter, you will always look at the peripheral blood in terms of the size and shape of red blood cells, the hemoglobin contained in terms of the chromia of the red cells, either hyperchromic or normochromic, or it could be more chromic or hyperchromic. Usually that term is not described, but usually it is normochromic or hyperchromic. Polychromatophilia denotes the reticulocytosis that is seen in the peripheral blood. Usually the cells are larger in size and they are polychromatophilic because they are various stages of reticulocytes. And when you look at the red cells, you could find that there are many inclusions that could be giving you a pointer towards the diagnosis. One is Howell jelly body, otherwise the basophilic stippling, and many times in anemia you can find malaria parasite in the red cells. So hemoparasite also is important cause of anemia, particularly in tropical country like ours. Rouleau formation is a very, very innocuous thing to be seen in the peripheral blood, but that can give rise to a clinical suspicion, particularly in elderly population, about plasma cell disorders, particularly multiple myeloma. WBCs is also important because a normal WBC count with anemia is different than anemia with a subnormal WBC count. So hypoplastic bone marrow or hypoplastic anemia, aplastic anemia, where WBCs and platelets will be important to look at. Besides hematological parameters, it is also important that you look at the biochemical profile of patients when you are considering to diagnose anemias. Urea creatinine is important. As I said, anemia of renal disease will have increased urea creatinine, and anemia of chronic renal failure is usually due to the subnormal erythropoietin levels in that. Bilirubin is important because some of the cases of megaloblastic anemia could have a mild increase in bilirubin. All the hemoglobinopathies usually have a higher bilirubin. So bilirubin is important to diagnose anemias, to give the pathogenetic mechanism of anemias. And this bilirubin could usually be mostly direct when it is in hematologic disorders and indirect when there is liver disease. LDH and haptoglobins and hemopexins are the ones that are usually decreased, elevated LDH, decreased haptoglobins and hemopexins in hemolytic processes. So it is important to look at the LDH, particularly in autoimmune hemolytic anemias, in thrombotic thrombocytopenic purpures, in many other lymphoproliferative disorders where there is anemia. So LDH is an indicator of cell turnover, and usually in megaloblastic anemia, which is the very common form of anemia, could have a higher LDH. Proteins are elevated. Either it could be polyclonal or monoclonal. In monoclonal, you may have Rouleau formation. Even polyclonal rise also could have Rouleau formation, but monoclonality will denote plasma cell neoplasms. Iron and serum iron studies, including TIBC, percentage transference saturation, are important to say that it is iron deficiency. So as ferritin, ferritin is important because it is the storage form of iron. And if there has been chronic blood loss or there is severe iron deficiency, you could find that the ferritin levels could be low. Folic acid, B12, they are due to megaloblastic process. And sometimes you may need to do folic acid assay and vitamin B12 assay. But these two assays are usually not very popular because the cost to treat a patient of megaloblastic anemia is much lower than doing the folic acid B12 assays. So physicians are more comfortable giving a therapeutic trial with B12 folic acid rather than asking for B12 folic acid assay in the laboratories. Urine we always neglect, but urine can give a lot of indication for the cause of anemia. Proteins, if you are checking with the dipstick, the light chains are usually missed. So if you have a light chain myeloma, you may not detect an increase in proteins by the dipstick method. RBCs can appear in urine. Hemoglobinuria could be seen, particularly in paroxysmal nocturnal hemoglobinurias and in other causes of hemolytic anemias. So looking for RBCs and hemoglobin and under the microscope in urine analysis is important. So mechanism of anemia, as I have already mentioned, that it could be decreased production, increased destruction, and blood loss, are to be found out as to what could be the cause of the decrease in hemoglobins. So the most common anemias that we encounter in our clinical practice is nutritional anemia, primarily iron deficiency, followed by B12 folic acid deficiency in our subcontinent. Then comes alpha thalassemia. Why I have put alpha thalassemia above beta thalassemia is actually, in fact, alpha thalassemia is the double deletion alpha thalassemia is much more common, which almost is like beta thalassemia minor, is much more prevalent than beta thalassemia minor as well as beta thalassemia major. So alpha thalassemia could only be diagnosed by molecular studies, but they can be suspected if you find that it is not beta thalassemia, but not iron deficient. So possibly it could be alpha thalassemia. So always the diagnosis is conjectural, but if you want to prove that the patient has alpha thalassemia, you have to do a globin chain study in terms of alpha thalassemia. Anemia of chronic disease is very common, particularly in the middle-aged and elderly, because large number of chronic diseases could give rise to anemia of chronic disease. There are other anemias which are also quite prevalent in the Indian subcontinent. Sickle cell disorder is very common in states like Odisha, in part of Madhya Pradesh, Telangana, Andhra Pradesh, Kerala, and in Gujarat. In certain pockets, in certain communities, it is quite common. Autoimmune hemolytic anemias, the acquired ones, and the ones that go with the lymphoproliferative disorders are quite common, and it produces autoantibodies against the red blood cell, the different epitopes of red cells that can lyse the red cells, either by intravascular mechanism or by extravascular mechanism. Folate B12 deficiency is already highlighted. Refractory anemias, particularly myelodysplastic syndrome, is a disease of the elderly. In India, it is about a decade and a half earlier than what you see it in the West. So we have seen MDS patients who are in their late 30s, early 40s, late 40s, and in the sixth and seventh decade. Aplastic anemia, usually a disease of childhood, but it can be seen at any age. So hypoplastic anemia is very common in the developing countries, in the far eastern countries, and the implication has been given that possibly it could be because of the increased frequency of pesticides being used in rice farming in the paddy fields. So you don't find so much of aplastic anemia in the Western population, but in the developing countries, particularly in the Far East and the Southeast Asian countries, aplastic anemia is very common. I am not talking about the hereditary forms of hypoplasia, that is Fanconi's and diamond blackfan anemia, which is a different entity altogether. Red cell membrane and enzyme defects are also common. The most common red cell membrane defect is hereditary spherocytosis, and the most common enzyme defect is G6PD deficiency, followed by the pyruvate kinase deficiency. I will skip this. This is a repetition. So when you talk about microcytosis, the first category of anemias, that is a morphological classification, how to do a differential diagnosis of microcytosis. The first thing that will come to your mind is the iron deficiency anemia, where you will find that you can have many exotic conditions that could be associated with iron deficiency as well, which you need to think about. Idiopathic pulmonary hemosiderosis is a very common cause of iron deficiency because most of the ferritin and hemosiderin gets deposited idiopathically in the lungs. PNH is a diagnosis of exclusion. And whenever you have aplastic anemia and whenever you have hemolysis, you always think about PNH because PNH and aplastic anemia go hand in hand because 1/3 of patients of PNH and 1/3 of patients of aplastic anemia will precede or succeed the phase of PNH and aplastic anemia. Familial telangiectasias, also with Osler-Weber-Rendu syndrome, is very common, and that produces iron deficiency as well. Alpha thalassemia, I have already highlighted. No simple test is available. You can only think about it after you have excluded iron deficiency and you have excluded beta thalassemia, in particular in Indian settings. Beta thalassemia minor is easier to diagnose in our hospital setting because you always look for the elevated hemoglobin A2 labels if they are not iron deficient. But in India, iron deficiency is so common, you have large number of patients who are not only iron deficient, but also carry the beta thalassemia gene in a heterozygous form. When you talk about anemia of chronic disease, usually the patients are normocytic and normochromic. However, there is an inadequate response of bone marrow to erythropoietin. So even though the erythropoietin is adequate, the bone marrow is not producing enough red cells in patients of anemia of chronic disease. You have many exotic hemoglobin disorders, particularly the CC type of disease, which is not prevalent in India because it is a disease of the Mediterranean as well as the Western Hemisphere. But hemoglobin EE homozygous disease is quite common in the Southeast Asian population. Here, either you have no anemia or very minimal anemia, but your MCV can be extremely low, even as low as 65 with many target cells. But patient may not be transfusion dependent because the anemia is very subtle and very minimal. Hemoglobin CC disease I will not discuss because primarily it produces anemia by intramedullary destruction of these red cells because of crystallization of hemoglobin C inside the red cells and the red cells getting destroyed in the marrow. These are a few pictures that I have picked up from the image bank of ASH. ASH has got a beautiful image bank, and if any of you are interested to look at the images of various hematological disorders, you can enter into this ASH site and look at the image banks. So this is one of the images of hyperchromic microcytic RBCs where you can find the profound hyperchromia that you find in the red cells, which are microcytic. So this is a prototype peripheral smear of a microcytic hyperchromic anemia of iron deficiency. If you look at this smear, you can find that there are a lot of target cells. There is some degree of anisocytosis, and this is the type of thing you can find in either severe iron deficiency because they are again hyperchromic. So target cells can be seen in severe iron deficiency anemias, in addition to thalassemia minor and many other hemoglobinopathies. So you have to be careful when you look at a lot of target cells in the peripheral smear. So this table will give you a glimpse of how to differentiate between iron deficiency, thalassemia minor, and anemia of chronic disease. This has always been a problem to say what is the cause of anemia, particularly if the patient has got some chronic ailment. So serum iron is usually low in iron deficiency, but normal to high in thal minor, and maybe low in anemia of chronic disease. Total iron binding capacity, percentage saturation, serum ferritin, free erythrocyte protoporphyrin, these are all part of the serum iron studies or iron homeostasis. And you can add hepcidin now these days to this list. And all these five will form the workup of iron deficiency anemia. They, as per this table, they are either high or low in different ways in these three disorders to differentiate them as far as laboratories are concerned. Free erythrocyte protoporphyrin is a test which used to be very prevalent in my younger days, but these days there are many other better parameters than FEP, so no one does this other than in a research setting. But serum iron studies like percentage iron saturation, TIBC, and transferrin saturation, hepcidin are very important to study. So sometimes you may have anemias which could be normocytic and normochromic with normal or reduced reticulocyte count. As you know, reticulocyte count is an important parameter in the investigation of anemia. So when you are investigating anemia, you must always ask for CBC with retic. Many times what happens, the reticulocyte is not asked for because most of the cell counters have got the reticulocyte mode, which is not part of the CBC. So you have to select reticulocyte count if you have to count reticulocytes because it's a fluorescence channel. So you have to select reticulocyte count to be counted when you are doing the CBC. So anemia of chronic disease is extremely important. As I mentioned, that you have reutilization defect, where the bone marrow macrophages would be full of iron particles, but your red cells will be deficient of iron because the mobilization of these iron into the red cells are improper. So in megaloblastic anemia with thalassemia or iron deficiency, you could have a normocytic anemia. Many times what happens, there is masking of microcytosis because of the concomitant presence of B12 folic acid and iron deficiency in the same patient. Endocrine disorders are very common, hypothyroidism, chronic renal failure, they all lead to normocytic-normochromic anemias. HIV infection, AIDS, though are decreasing in incidence, but it is also one of the causes of anemia because of normocytic-normochromic red cells. Bone marrow infiltrative disorders, whether it is solid tumors or any other tumor that infiltrates the marrow, will produce normocytic-normochromic anemia. And lastly, myelodysplastic syndrome can produce normocytic-normochromic red cells in addition to the macrocytic cells that usually are found and associated with MDS. But sometimes the red cells could be normocytic-normochromic. So the other things that can be seen in certain individuals where you have normocytic-normochromic anemia with increased reticulocyte count. The previous slide showed with normal to reduced reticulocyte count, but here you have blood loss anemia where you will have normocytic-normochromic red cells, but you will have an increased reticulocyte count because of the reticulocyte response. Hemolytic anemias, the hallmark of hemolysis is reticulocytosis. So blood loss and hemolytic anemias will produce increased reticulocyte count, and that you need to correct for the degree of anemia. So corrected reticulocyte count also will be high in these two disorders. So this is an algorithmic approach to the peripheral blood smear where you are investigating a patient of hemolytic anemia because you are likely to find these type of cells in the peripheral blood. You can find spirocytes, you can find cystocytes, you will find specific morphological features, and you may find no morphological features or no specific features as it is seen in G6PD. You may not find anything in the peripheral blood. So when you talk of spirocytes and you do a Coombs test, you will find that the Coombs test could be positive, depicting that it could be immune hemolysis, it could be negative, saying that it could possibly be hereditary spirocytosis because the peripheral smear will be full of spirocytic cells. They could be normospirocyte, they could be microspirocytes. Cystocytes, you will find that you will have valvular disorders. You can have valve disease, intracardiac necroma. Left atrial necroma. Small vessel disease like TTP, DIC, malignant hypertension, adenocarcinomas, particularly the ovarian adenocarcinomas, and pancreatic carcinoma can produce cystocyte. Eclampsia, preeclampsia also can produce fragmented RBC. These days, automated smart blood cell counters can give rise to cystocyte numbers. Absolute numbers of cystocytes can be counted in the recent current generation of blood cell counters. Sickle cells, elliptocytosis, spur cells, bird cells, target cells, all can be picked up by automated blood cell counters. And if you add the cell of vision, which is nothing but digital hematology, can all pick up. Even without looking at the peripheral smear under the microscope, the machine will give you what type of abnormal red blood cells are seen in the particular patient. G6PD, pyruvate kinase, and other enzyme defects like 5-nucleotidase deficiency, and in PNH. All these are the diagnosis of exclusion, but G6PD is very common in India. And particularly if the patient is a male, you must exclude G6PD by doing a G6PD semi-quantitative or a quantitative assay. If you look at this image bank slide from the ash, you can find that you have large number of microspherocytes like this with loss of central pallor, and this is a slide of hereditary spherocytosis. But the same picture can be seen in uh, autoimmune hemolytic anemias as well, where you can find large number of spherocytes. Both will produce reticulocytosis. So reticulocytosis will not exclude them, but you need to do other assays. You can do the 5-EMA assay by flow cytometry to exclude hereditary spherocytosis, and you can look for the PNH assay by looking at the CD55, CD59, and other factors, other red cell membrane protecting proteins by flow cytometry. So this is another one which shows that there is a nucleated red cell with a lot of basophilic stippling. And this usually happens when you have splenectomized the patient, particularly in patients of thalassemia, patients of refractory autoimmune hemolytic anemias, where you have no other choice because all the therapeutic modalities have failed. And the only way you can increase the hemoglobin is by sacrificing the spleen. Sometimes in certain disorders, you can undergo autosplenectomy, particularly in sickle cell disease, where you can find in an autosplenectomized patient these nucleated red cells with basophilic stippling and reticulocytosis and some degree of anisopoikilocytosis in patients who are splenectomized. So hemolytic anemias are extremely important, and usually they can evade diagnosis because sometimes it could be compensated hemolytic anemia where the reticulocyte count has stabilized to the normal levels and you have not asked for the Coombs test upfront to detect it. Sometimes the Coombs test can be negative, even there is autoimmune hemolysis, because there are various modifications to Coombs test that needs to be done in a center which is geared up to do various modifications of Coombs test, particularly the enzyme-treated red cells that can be subjected to the Coombs test. The Coombs test, direct negative, indirect positive, delayed transfusion reaction could have this because it can produce alloantibodies. So post-transfusion alloimmune anemia can be seen. Hereditary spherocytosis. No more anyone does osmotic fragility these days. You do the 5-DAS melamide assay, which is a flow cytometric assay, which is much more sensitive. And the disorder is usually autosomal dominant, so a family study and a spectrin anchoring analysis by polyacrylamide gel electrophoresis can detect these abnormal red cell membrane proteins. Splenectomy is much later these days because we have large number of other avenues available to avoid splenectomy. Sickle cell disease, very common in Odisha, the state to which I belong to. Large number of patients used to be admitted to my medical college with sickle cell disease with all kinds of complications. Very easier to detect. If it is in homozygous state, you will find that the simple peripheral blood smear will show sickled RBC. And if you do the sickling test using sodium metabisulfite, you can find sickle cells, and you can do a solubility screening test to show that these sickled RBCs are less soluble than adult hemoglobin. And you can do electrophoresis to find them. Elliptocytosis is also a type of red cell membrane disorder. I'll not go into the details of that, but it produces chronic hemolytic. So hereditary elliptocytosis many times go unnoticed because people consider that probably they're artifactual in the peripheral smear. But consistently, if you find elliptocytes in a patient who has got low hemoglobin and mild reticulocytosis, please consider that those elliptocytes as part of elliptocytosis. So here you can find that there are large number of microspherocytes and macrocytes with polyphemusia. So these are usually seen in hereditary spherocytosis and autoimmune hemolytic anemias, because the polychromatophilic cells will be macrocytes, and because of the secondary folate deficiency, because of the chronic hemolysis, you can have secondary megaloblastic anemia because of the persistent hemolysis that takes place. This is hereditary elliptocytosis. You can find that majority of the cells are elliptocytes. This is sickle cells that you can find. You cannot miss it if you see it. So hemolytic anemias, other than what you are classically you see, you can have acanthocytosis, you can have bird cells, you can have target cells, and they are exotic conditions. You can find acanthocytes in hereditary acanthocytosis. You can find them in certain neuroacanthocytosis, where you have the cerebellar disorders, and you can find them in end stage liver disease, and you can find Burr cells in uremia, in pyruvate kinase deficiency, and target cells. As I mentioned, that classical target cells are seen in homozygous hemoglobin CC disease. But also you can find in homozygous E disease, you can find in double heterozygous sickle C disease, and you can find it in sickle beta thalassemia. All can give rise to target cells. And this is one dirty smear. You may pass it off as poor quality smear and throw it away, but you will find that in severe liver disease, sometimes you can have a peripheral smear which can look like this. So don't ignore it. If the second time you get a smear like this after throwing the first one, please do consider the liver function test and consider hemolytic anemia due to severe liver disease, and this could be a picture which could go with that. Obviously, enzyme defects, two things that you must keep it in mind, A6PD and pyruvate kinase. Others are esoteric. So for that, you have to send the sample to none other than the center in Bombay, the Institute of Immunohematology, who has a facility to detect 5-nucleotidase deficiency and other exotic red cell enzyme defects. Intravascular hemolysis, no one does serum haptoglobin and hemopexin labels. They are theoretical, and every postgraduate student will be asked, what are the other things in the serum that you can study to say that there is intravascular hemolysis? Normally, people forget haptoglobin and hemopexin. Urine hemocysteine is the simplest of the tests for chronic hemolysis, intravascular hemolysis, because when this hemoglobin passes through the proximal convoluted tubules in the kidney, they are reabsorbed by the tubular cells, and they are degraded. The hemoglobin is degraded, and you will find that these are converted to hemocysteine. And when you examine the Pearl's reaction on a urine deposit, you can find that large number of these epithelial cells of the renal tubules will have Pearl's positive granules. So simplest of tests, and often missed out, to be ordered for in chronic intravascular hemolysis. This is to detect that you can have bite cells, helmet cells. All these are description of red blood cells in hemolytic anemias. Blister cells. Blister cells are usually found in these 6PD deficiencies. So you must look for these. If they are present in significant number, don't ignore them. You must write it in the description that you are finding fair number of bite cells, blister cells, helmet cells, basket cells. There are many names to it. So in chronic intravascular hemolysis, you must consider if the patient has got a cardiac burn or there is PNH. And PNH, as I said, first investigation is urine for hemocysteine. Then no one these days does Sidrod's hemolysis test. No one does the HAMS test. We do flow cytometry by using many other antibodies other than 55, 59, 36, 16. So you look at the WBCs and neutrophils and monocytes for the deficiency of these GPI-anchored proteins. So there is a deficiency of the GPI-anchored proteins in PNH, which you can check by flow cytometry. Usually we don't study the red blood cells because majority of the patients who are suspected to be having PNH are transfused, and transfusion will obviate the result of CD55 and 59 on RBC. So WBCs are a better way to study for PNH, and you can see the PNH clone to the extent of 1% or even lower if you look at the monocytes and neutrophils by flow cytometry. So this is the microangiopathic smear, where you can find this fragmented RBC, there is thrombocytopenia, and there are some microspherocytes. So this is a classical hemolytic picture of microangiopathic hemolytic anemia. So MAHA is a medical emergency, whether it is TTP or HUS or HUS TTP. And sometimes in DIC also you will have exactly a similar picture of microangiopathic smear. So macrocytic-normochromic anemias, when you have a MCV that is neither normal nor very abnormal, just borderline macrocytic, just borderline normocytic. So there are large host of conditions that can happen: chronic liver disease, hypothyroidism, which is so common in the middle-aged ladies and in young females as well. Drugs, particularly hydroxyurea, methotrexate, can have that. So this is the reason why you treat patients who are given methotrexate with folinic acid in leukemias. Primary bone marrow disorders like aplastic anemia, MDS, myelomas, leukemias, lymphomas can all have this. Bone marrow infiltrative disorders like miliary tuberculosis, metastatic carcinomas can produce a macrocytic-normochromic type of anemia. You can find this when you have macroovulocytes. You see, macroovulocytosis is very commonly seen in megaloblastic anemias. So you must look for them, and they are the ones which are here. It is bordering 110. Around the MCD will be about 110. So this is clearly on the megaloblastic side, and you can supplement it with macropolycytes, which are hypersegmented polymorphs, and sometimes you can have macro teardrop cells. So this is how you differentiate folic acid and B12. I'll not go into the details to save time. Important points about anemia. This is very important, this particular table. The reticulocyte peaks around 1 week, which is called the reticulocyte response when you treat patients of iron deficiency and B12 folic acid deficiency with the therapeutic agent. So always do a baseline reticulocyte count and look for the retic response by around day 7, between 5 and 7. If you do it after 7 days, the retic response would have plateaued and you will not get any informativeness to that test. The hemoglobin and hematocrit will increase to normal in about 6 to 8 weeks if there are no other complications in patients who are treated with B12 folic acid and iron. But the serum ferritin storage form of iron would not have normalized in 6 to 8 weeks. So it is important that you must treat severe patients of iron deficiency at least with 3 months of iron therapy. The other thing is that if you have a reticulocytosis, which is more than 1% of the normal levels, usually there is increase in the MCV by about 1 femtoliters. So sometimes what happens in chronic hemolytic anemias, you have chronic reticulocytosis, which is not grossly high. So these are the ones who are called compensated hemolytic anemia. So reticulocyte count will not give you any information about the hemolytic nature of the anemia, but these patients are usually considered as compensated hemolytic anemia. LDH is very important. LDH is increased in megaloblastic anemia in the range of 1,000 to 3,000 units per mil. And the MCHC, as I have already said, in hereditary spherocytosis, it has great utility because the acquired spherocytosis, as you find in post-transfusion blood and peripheral smear. You can have acquired spherocytosis. So high MCHCs will suggest this, that it could be hereditary spherocytosis, but usually not acquired spherocytosis because they are very few in the smear and will not contribute to the MCHC. Bilirubin not over 4 milligram per deciliter with hemolysis. So you have to look at the bilirubin, whether they're direct or indirect, and then reach a conclusion whether it is a hemolytic type of hyperbilirubinemia or hepatic type of hyperbilirubinemia. I have just two cases, please. This is a 45-year-old female, 3-month history of fatigue, shortness of breath on exertion, on examination, double plus pallor, and the full blood count showed that the hemoglobin is 6.2 grams per deciliter. So you definitely need a complete blood count, and here is the complete blood count. You have a white cell count of 7,000, platelets are normal. MCV is markedly low of 60 femtoliters with lower mean corpuscular hemoglobin. And I have said that MCH is of not much use, but still we look at it. White cell differential is normal and the blood film was done. So when you find that the blood film had hypochromic anemia, you have few options. You will immediately, since you have already seen that the red cell is hypochromic microcytic, you will ask for ferritin. If it is reduced, that points towards iron deficiency. Also, you cannot exclude anemia of chronic disorder, so history is important. But if the ferritin is normal, you will think about hemoglobinopathy. So in hemoglobinopathies, ferritin is either normal or increased. But if it is significantly increased, you must consider sideroblastic anemia. Sideroblastic anemia again are of two types. You can have acquired sideroblastic anemia and you can have hereditary forms of sideroblastic anemia. And you may have, if you do not have sideroblastic anemia, you may have other causes of high ferritinemias, which you may consider. Say anemia of chronic disease, high ferritin, because the chronic inflammatory state. So ferritin will be very high. Suppose you have hemophagocytic lymphohistiocytosis and you do a serum ferritin, it will be in 10,000. So that is one of the diagnostic criteria for hereditary hemophagocytosis. So what further investigation should be carried out in this case? So you have done serum ferritin along with serum iron studies. You will ask for B12 folate as well, and you will have screening for a host of conditions. What could be the cause of the celiac disease? You will do a GI endoscopy. You will do a gynecological referral. So all these are consultative hematology and consultative specialty referrals, which are important for arriving at the conclusion. Many times you may need to do a coagulation screen, you may do a mononuclear disease screen, and you may have to do a hemoglobin electrophoresis if you are thinking in terms of a hemoglobin disorder, which is not so obvious in a peripheral blood smear examination. So hemoglobin electrophoresis in anemia is important. These days we do HPLC, we don't do electrophoresis. You do electrophoresis only when your HPLC is uninterpretable and inconclusive. Raised ferritin labels can be seen in acute inflammatory states, chronic inflammatory states, acute liver disease, in lymphomas, solid tumors, hemochromatosis, particularly the primary form of hemochromatosis, which has the HFE gene mutated. But you can also have secondary hemochromatosis in many disorders where patients are transfusion dependent and you have problems of getting rid of the hemoglobin. Anemia of chronic disease, I will not go into the details. I have mentioned that chronic inflammatory states like rheumatoid arthritis, ulcerative colitis, ankylosing spondylitis, all those connective tissue disorders can produce ACD. Mechanism is either due to shortened red cell survival, impaired marrow response to anemia or utilization of iron to red cell erythropoiesis, impaired erythropoietin production, and defective iron transport. Everything contributes to anemia of chronic disease. I think I have mentioned this. So acquired hemolytic anemia, as I mentioned, that this could be autoimmune. In most cases, it can be alloimmune, particularly post-transfusion, and it could be drug-induced, where you can have a innocent bystander mechanism. These days, a large number of drugs are given, and some of these drugs can produce a hapten model of drug-induced um, hemolytic anemia. Thereby, the neoantigen that gets formed bind to the red cells, and there is complement activation, and the red cells, they die inside the spleen because they will have extramedullary destruction in this clinic sinusitis. I'll skip this warm antibody, cold antibody type. Hemolytic transfusion reaction is very important, particularly in minor ABO mismatch transfusion. Hemolytic disease of the newborn is important when you have RH incompatibility. And both these are mostly due to alloimmune hemolytic anemias, and they're self-limiting. After the immune antibodies, which are alloreactive, they are cleared, the hemolytic anemia decreases. Non-immune hemolytic anemias, red cell fragmentation, infections, physical chemical injuries. I think I am coming to the end of my talk. Warm antibodies could be auto, and cold antibodies could again be autoantibodies. They produce Raynaud's phenomena, positive DCP, complement activation. Cold agglutinins, you can find that the peripheral blood smear is showing autoagglutinins. Inherited hemolytic anemias, I have already said about hereditary spherocytosis. And this is autosomal dominant with a small cohort of a subset of patients where it could be recessive. Variable severity, you must do family screening if there is a patient who is severely hemolyzed. Red cell membrane defect, you should look for 5 EMA study by flow cytometry. Pyruvate kinase is the second most common cause after D6PD. Erythropoietic regulation of hepcidin. This is my last but one slide. Why I've kept it to the end, because hepcidin has now took center stage in the investigation of anemias. So when you have iron deficiency, and when you have patients who are refractory to iron deficiency, refractory to iron treatment, you call them as iridia, iron refractory iron deficiency. My next slide will highlight on that. So where here you have increased erythropoietic demand for iron that reduces hepatic hepcidin synthesis. So hepcidin is synthesized by the liver, and the erythropoietic response controls it. So hemolysis, hemorrhage, administration of EPO lowers the circulating hepcidin concentration. And where there is marked ineffective erythropoiesis, like what you get in beta thalassemia intermediate, you may have very low or absent plasma hepcidin, thereby increasing the iron absorption. That is the common cause of increased iron in the bone marrow and in the medullary space. In spite of high plasma iron, there is no negative feedback for decreasing the iron absorption. So erythropoietin is a physiologic regulator. This is what the mutation status is. These days, everything is genomics, whether it is oncology and non-oncology. This is what you look at. So you look at these genes and what you do. So whenever you have refractory iron deficiency anemia, ask for clinical exam sequencing. So when you have clinical exam sequencing, if it is IRIDA, you will find the TMPRSS gene mutation. And in addition to that, there are a large number of other mutations in esoteric refractory anemias. This is a diagnostic algorithm, quite a little complex, so I'm not going into the details. At the end of it, you will find that this is oral iron refractory. Patient is not responding to iron administration in spite of microcytic hypochromic red cell. So you must suspect iron refractory iron deficiency anemia. Not many people suspect until unless they are in the setting of hematology. But the idea of this presentation is that my young postgraduate colleague should consider that this is a reality, and they must ask for serum hepcidin labels to diagnose this. And also do not forget to ask for this TMPRSS6 gene mutation, which confirms IRIDA by sequencing of 18 exon intron boundaries, and this mutation will actually clinch the diagnosis that the patient has got iron refractory iron deficiency. So in addition to that, you'll always exclude celiac disease, H. pylori infection, autoimmune gastritis, all are causes of reduced iron absorption in the gut, because the iron is always absorbed in the first part of the duodenum. So it is important that you must look at these and also consider this TMPRSS6 gene mutation, because that produces iron refractory iron deficiency. And with that, I finish my today's session of the talk on anemias. And in my next talk, which will be the next week, I will consider more cases, case-based discussion, so that I hope it will be a little interactive, because when I show a case, I will ask a question, and I expect that the audience will uh, raise some answer, answer some question, so that the discussion can happen. So the session is now open for discussion. In case anybody has any queries, I would be very happy to take a couple of them. Thank you very much. And once again, my apologies for starting it late, and I have exactly finished in 65 minutes. So thank you very much. And I'll now hand it over uh, to the moderator to moderate this session.
Right.
And
Thank you.
this is my last slide. I am showing you the beautiful picture of coronavirus. You know, we are here like this because of this virus. I am speaking to you from a faraway place because the coronavirus has made us so apart that we can't meet each other, we can't greet each other, and we are speaking on the screen and seeing each other on the screen in a virtual mode. Thank you very much.
Thank you very much, Dr. Mishra, for a excellent presentation. And you have given a very practical approach and a very systematic approach how to proceed in cases of anemia, starting with MCV and going forward to diagnose any case of anemia. We have a few questions. There is a question from Professor Pranab Kumar, that what is the role of flow cytometry, especially the flare investigation in diagnosis of PNH?
Yes, the flare and the CD55, 59, 14, 16, 36 are important. They're all GPI anchored proteins which are deficient in PNH. So you look for them. You look for the mean fluorescence intensity, and you look for the expression labels on the PCs for a diagnosis of PNH by flow cytometry. And this is a routine test now in most hematology centers and laboratories for the diagnosis of PNH.
There is another question on role of flow cytometry, where we are using EMA binding test for diagnosis of spherocytosis.
I have already mentioned about the 5-EMA test, which is a very sensitive test for the diagnosis of hereditary spherocytosis. In this, you have to study at least 5 normal individuals along with the patient when you are looking at the 5-EMA binding assay. And this is a highly sensitive test, much better than OFT and incubated OFT for the diagnosis of hereditary spherocytosis. The other test that matches with this is something called osmotic gradient ectocytometry, which is also an automated test. But that is an automation in OFT called osmotic gradient ectocytometry, which is little less sensitive than the 5-EMA binding assay for osmotic for hereditary spherocytosis.
Dr. Mishra, there is another question. Is bone marrow examination essential for diagnosis of sideroblastic anemias?
Yes, definitely. Sideroblastic anemia not only will have bone marrow changes, but also you must look at the the granules, the iron granules in the erythroid cells. Because sideroblastic anemia, just like you find ring sideroblasts in MDS, similarly here also you will find large number of sideroblasts in sideroblastic anemia, and they are not linked to the mutation that you find in RARS. The SF3B1 mutation is not linked to this sideroblastic.
What is the blood picture in cases of double deletion alpha thalassemias? Is it the same as microcytic hypochromic, what we find in 3 gene deletion in HBH disease, or is it different?
No, in double deletion alpha thalassemia, it is very subtle. It exactly mimics beta thalassemia minor. But
Okay.
your HbA2 will be normal, your molecular studies for beta thalassemia will be normal until unless you look them up by globin chain synthesis for the alpha globin chains, you will miss them, and you normally consider them as alpha thalassemia by looking at the red cell indices and excluding beta thalassemia and iron deficiency, and then say that this patient possibly have double deletion alpha thalassemia. Triple deletion is always HPH, where you'll find the hind bodies in the red cells if you do a hind body preparation.
Are there any studies in India where one could say that double deletion alpha thalassemia is more prevalent than beta thalassemia trait?
Yes, yes. I think there have been some community studies done by IIH in Mumbai, and they have said that alpha thalassemia is far commoner than beta thalassemia minor.
Right. There are no more questions. Thank you very much, Dr. Mishra, for such a nice presentation, and I'm sure that the second session is going to be more interactive.
I always feel blessed when you moderate the session.
Thank you so much, Dr. Mishra. Over to you, Dr. Vatsala Mishra, President of IAPM.
Thank you, Dr. Mishra, for the presentation, sparing your time for taking this webinar, which is really very informative and important for the PG students, because they are our backbones, and we have to see that they learn the basic things, which is more important. And it was a very nice and very elaboratively covered, but in the systematic manner. That was the best thing of your presentation today. So we hope in the next, as you said, you will take up the cases and we will have more discussions. So once again, thank you for sparing your time. Now, Asranti, what next you have to do? Can comment from Dr. Mohanty, sir? Can Dr. Mohanty?
Thank you, Dr. Mishra. I am privileged to hear your lecture. It's a very simplest way. You have made the most commonest clinical condition in a very simple manner, so that I could remember. Within my time, only the hematology means electrophoresis and the bone marrow. That ends there. And Dr. Javi Chatterjee. Now I see it's a very nice way and very simple manner and concise way you have presented the thing. Thank you very much for your lecture.
Thank you, sir, for being there.
Thank you. If there